Hello, and welcome to the Within Health Summit 2022. My name is Jamie Singletary, and I am the Director of Family and Alumni Programming. And I am excited to be able to introduce Dr. Wendy Oliver-Pyatt, who is the co-founder and Chief Executive Officer of Within Health. And she is going to be speaking on breakthroughs in treatment, past, present, and the future of eating disorders. Take it over, Wendy.
Thank you so much, Jamie, again, we're wrapping up a really amazing 3 days. Like, it is amazing to me that so many people came together from our community and then also from within to create really an innovative kind of platform. That's why it's called a summit, where we've brought together so many interesting people from different, walks of our community. And in the past, all of our conferences have really been within the eating disorder space. And I'm super excited that I've been able to meet people from completely different worlds than we're in. And it just really shows the power of connection and the power of communication, and that, our world is a complicated place. There's lots of crappy things happening in the world, but there's so many wonderful humans in our world, trying to make the world a better place, as cliche as it sounds. So this has been amazing. And you, Jamie, and Cynthia Johnson, just Cynthia was really the brainchild, and you were also the brainchild, and you did a lot of the heavy lifting. So thank you so much. And I really want to extend such gratitude to my co-founder, Abhilash Patel, and Rebecca Brum, and all the team at Within Health, the people that make our beautiful websites. I just could go on and on. Mateo, shout out to our IT director, been with him for a while. So without further ado, as they say, I'll continue on with this talk. So the idea behind this talk today actually came from a little chuckle I had within when I noticed that in the eating disorder community, people were really like advertising and really proud to be health at every size providers. And it struck me as I was noticing this over and over again, it struck me all that we've been through in the field to get to a point where health at every size really was something that people conceived of as legitimate and conceived of as an important foundation. We have come a long way. There was a time when those of us who really were very attached to this approach, we were laughed at a little bit. The eyebrows were raised. And I was doing what is called health at every size before I even knew it had a name. And sometimes people didn't, accept what I believed in. And so it dawned on me, though, in that moment, that there have actually been breakthroughs in our field. And I thought, after 20 years, let me try to conceptualize what some of those are. And that is how the idea for this talk came. And I am so lucky that I've been able to work in the field for all this time because of the support of so many people, other people like Chrissy Stockard and Jessica Janae and Wendy Shove, who've been with me from the very beginning, some of our care partners, Crystal, Stacy. The only reason I'm here is because of all these people. And I'm sorry, I can't even think of everybody right now, but there's so many of you, so many of our care partners, and that have just been the lifeblood of our program. So I will continue along here. So the breakthroughs that I felt would be most significant to talk about that I've noticed over these 20 years or so treating eating disorders was the following, or are the following. That treatment became trauma informed. We were allowed to actually think about trauma. I'd like to talk a lot about trauma because all the other stuff that's really breakthroughs it's all very connected back to trauma, whether it's the emergence of health at every size and the awareness about weight stigma, diversity, inclusion, dialectical behavioral therapy, and even some about remote treatment is all tied back to trauma. So a lot of the conversation today is going to be about trauma, but I just want others to know that are newer in the field. There was a time when we weren't allowed to, by insurance payers, we were not supposed to address trauma. during treatment. And that is really something that now we sort of take for granted, and programs sort of market to that. We were actually told by reviewers that we were not to discuss or work on trauma. One of the other reasons why I really am honored to give this presentation is I have the honor of bringing out and honoring some of the game changers in our field, and that's a big deal to me that I've actually been able to do that. And I was able to interview several people that we're going to talk about today. Dr. Timothy Brewerton, who really affected the trauma treatment. Shavis Turner, she and I were very interconnected, developing the Binge Eating Disorder Association, and we started the Weight Stigma Awareness Week, and we were really frowned upon for how staunch we were with health at every size. But it's my honor to honor Shavis, and then diversity and inclusion. Dr. San Chang, I was able to interview them and learn so much from that. And I realized how much more there is to learn, addressing the need for inclusion in treatment, which is at the heart of Within Health also. And then of course, dialectical behavioral therapy, Marsha Linehan, DBT is probably the most well-studied type of intervention for treatment of many different conditions, including eating disorders. And I'll end the talk today by talking a little bit about the entrance of virtual treatment. I was having a meeting with our VP of design for Reed, and we realized it's not really virtual treatment. It's called virtual. It's not virtual. It's real treatment. It's just remote. It's not in the same place. But it is real treatment and real relationships. So you're going to hear me saying more and more, you're going to hear me saying remote versus virtual. Just a warning. This is a quote from Rosa Parks that has helped me in many situations. You must never be fearful about what you are doing when it is right. And as I've proceeded in the field for over 20 years, there's been times when people didn't feel what I was doing right by addressing trauma or health at every size approaches, and even getting some eyebrows raised, I think, in the development of Within Health. And I have had times where I've had to ask myself, like, Wendy, what is the right thing to do? What do you feel is right? And I've had to trust myself. Obviously, I have a lot of people that have surrounded me to help me, check myself. But this is something that I really have to hold on to at times when I've encountered challenges in my life. And, whether it's the development of Within, and some people thinking, oh, how are you doing this like virtual treatment? And it's sort of like somehow or another the stepchild. I'm here to tell you it is not the stepchild. It's a different kind of treatment. And in some cases, it's better for some patients. And sometimes it's the only option for patients. And then sometimes it really helps reduce the risk of recidivism after treatment. So there's a lot to offer with remote treatment. And we'll talk, and I'll share some outcomes. All right. So by addressing trauma, by addressing diversity and inclusion, by addressing weight stigma, and of course, DBT covers all of these, is the opportunity for empathic attunement to the whole person. And when we're missing any of this, we're really missing very important components of the treatment experience that the patient needs. And if we don't address these things, we're doing such a disservice to our patient, because I call it chasing behavior. When we're focused just too much on the outward behavior of the eating disorder, which is important, but we also simultaneously have to be addressing the underlying dynamics at play and risk factors at play that are pushing forward the emergence of an eating disorder. So we have to do it all. It has to be a biopsychosocial approach. But to think about the fact that there was a time not that long ago when trauma wasn't supposed to be led into treatment, when people didn't even know what weight stigma was, they never heard of it. And when diversity and inclusion wasn't even a thought, and treatment was really, generally speaking, available to a very, very small sector of people who experience eating disorders. As I mentioned, Dr. Timothy Brewerton, psychiatrist, clinician, and researcher, is to be honored. Shavice Turner, founder of the Binge Eating Disorder Association. She's also one of our advisors. San Ching, author, advocate of A Clinician's Guide to Gender Affirming Care, and Marsha Linehan, who, believe it or not, I tried to interview, but she said no, she doesn't give interviews anymore. So we tried. So this is what we were just talking about, that these breakthroughs came into treatment. Getting back to BED, binge eating disorder, it wasn't even included in the DSM, didn't come in until DSM-5. Health at every size actually started to become accepted. And then even more recently, diversity inclusion. I've really seen a change in the field. And I've made so many mistakes that are tied into my ignorance around diversity inclusion, particularly in the transgender population, which is why I did interview San Ching. We also have Skylar Baylor on our advisory team, who's also done a great job being an advocate and educating me. And I think our whole team, which has been a true blessing. And then DBT was barely even known in the early 2000s. I was super lucky because my first treatment center was in Reno, Nevada. And we had the University of Nevada, Reno right there. And we had a gentleman, a psychologist named Alan Frusetti at the University of Nevada, Reno, where Center for Hope of Sierras was located, my first treatment center. Alan Frusetti had trained at University of Washington under Marsha Linehan. I actually got a couple of psychologists working for me at Center for Hope of the Sierras who trained with Alan. So here it was, the early 2000s, people were not really talking about DBT. And by the grace of God, I became exposed to DBT and also acceptance and commitment therapy, because Steve Hayes was also at the University of Nevada, Reno. So I got very early exposure to DBT and ACT. I was able to introduce that into treatment before it was really known in the field. It was just because I was blessed. I happened to be where that was. So I've been introducing and utilizing DBT skills, but I'm far from a fully embraced DBT program the way you will see some programs, but such a great honor for me. I remember the first time my first clinician ever taught me about the principle of validating the valid and invalidating the invalid. And I said, oh my gosh, I was so concerned about making sure I validated the valid that sometimes I leaned into validating the invalid. And this lovely psychologist pulled me aside and she was like, you got to invalidate the invalid too. And I said, okay, I get this now. So that was amazing that I had that opportunity when I first started my first treatment center. Okay, so we're talking now about trauma. So, trauma presentation, this is going to be the bulk of our talking about trauma. By the way, this is a 9.5-hour talk. So maybe at some point I'll engage when I'll take a little, give everybody maybe a 10-minute break. I'll keep track of time and just wanted to mention that. Or Jamie, if you think, or if other people want, can recommend on, hey, like take a little break, let me know. So I know it's like a Friday afternoon and it's a long talk for the end of the day on a Friday. But we can certainly do that. Getting back to this. So trauma takes so many forms and is such a part of our patients' history as they enter our care. And we were told that we couldn't, treat trauma when people were in higher levels of care. So getting back to the idea of chasing eating disorder behavior versus addressing the trauma, it occurred to me, as I was being a clinician and working in the space, that so many of the behaviors that appear with food are really, in a sense, one of the same behaviors or responses or reactions related to trauma. So something that's the avoidance of trauma seen in trauma, that avoidance cluster of symptomatology, you can see the way it's played out in the relationship with food. So that emotional numbing, the sort of anhedonic response, the apathetic response, the detachment, that is something so prevalent in trauma. And in eating disorders, you see that restricting anorexia, not just like restricting of anorexia nervosa, but any kind of restricting. So that avoidance, restriction of motion, the apathy, that disconnection. So that's what we see. We see avoidance in eating disorders behaviors, just like avoidance of trauma. Arousal, so that exaggerated response to feeling full. The faulty alarm system, where you're really activated around being a little bit of food in your body, but not activated around not eating at all. So this exaggerated responses to things, to the startle effect and hypervigilance, certainly see the hypervigilance in the eating disorder behavior as well. And then the reliving of trauma seen in just the complete takeover of the mind related to food. And I've seen time and time again, as you address the eating disorder, you can start to uncover the underlying trauma. So we have to be careful in treatment, because we have to treat the eating disorder and the behaviors of the eating disorder. We have to also make sure we're treating the trauma. And if somebody starts getting into that resistance, quote, resistant, I'm saying, quote, resistant, into feeling like they're resistant, and you're chasing their behaviors around, and you're having to do all this stuff to apply external barriers to the patient engaging in behavior, you're very possibly not getting into the underlying issues that are driving the behavior. So there is something that is so worthy of note, which is complex PTSD, which now has a place in the ICD, does not have a place yet in DSM. This was super validating for me to discover that the ICD actually made a place for CPTSD, because so many of our patients didn't have that presentation of PTSD that you find in the DSM. And this is really an anxiety condition caused by severe repetitive abuse over a longer period of times. And it can be related to childhood trauma, but that trauma can be in the form of neglect and a lot of other things, despite different than the types of trauma seen in quote traditional PTSD. So other ways that complex PTSD shows up is just basically neglect of emotional needs, and invalidating environment, abandonment, which I think abandonment can come up in a feeling of abandonment certainly can come up in divorce situations. Betrayal can come up in divorce situations when there's a new family unit or new partner of a parent and siblings. And these are very deep, complex dynamics. Actually, moving can be really traumatic for patients. I've seen many people go through different moves that were particularly traumatic. And then the more obvious, certainly racism and oppression. It was just recently National Coming Out Day. I believe it was on the 11th. And I was seeing that we had made a post about that. And it just got me to thinking that it's sad that just now has sort of been, that National Coming Out Day is not that, it hasn't been around that long. And the clinician I was talking to today told me that yesterday one of her patients came out to her, and it was just it gave her chills. And just the idea that people have to fight so hard just to actually have a seat at the table, just to say I mattered. And certainly with racism and any form of oppression, that's the way it feels, that chronic feeling of neglect, oppression, not having a voice, being treated as less than. That is some hellacious stuff that people endure. And I'm somebody that I think it's important, as I'm speaking right now, come to think of it, to acknowledge the incredible privilege I have right now to be able to be at this platform and to be able to be in this life circumstance that gives me the opportunity to connect with people on a much bigger level or broader level. And the privilege of that, of having a voice, the privilege of having a voice that, as a female psychiatrist, quote, higher socioeconomic background, in a position of leadership in an organization, I have a platform for a voice. So many people have no way to speak up and be heard. And that is oppression. And that is traumatic. So with CPTSD, you do see avoidance, hyperarousal, and reliving, but you also see other aspects of trauma that we oftentimes see in people that we sometimes call borderline personality disorder. My least favorite term in the DSM-5. I just don't like that term. But other symptoms such as difficulty controlling emotions, negative self-view, difficulty with relations, detachment from the trauma, and loss of a system of meanings. So, a little bit about trauma doesn't go very far unless we also acknowledge, tied into breakthroughs, tied into all the work Timothy Brewerton did, is a greater body of, not greater, but significant body of knowledge that has really been additive. That's a part of the breakthrough in treatment having to do with trauma, which is epigenetics. Now, if I was in a room with everybody right now, I would be so happy because I would say, how many of you guys have heard of epigenetics? And then people could raise their hand and I could see who was in the audience. I don't get that. I'm just talking to a screen and I can't see any of you. But I guess, I don't know if people can wave. Well, anyway, I don't know how many of you know about epigenetics, but it is such a fascinating area of biology. And it is a big breakthrough that we understand this. When I went to college in the 80s, I was my major was biology. I had a double major, biology, psychology. So I was studying a lot of biology. And we were trained just Darwinian evolution and our biology changes based on Darwinism. And it's Darwinian evolution really has to do with the DNA changing, deoxyribonucleic acid, just a chain of amino acids. And in response to stressors or challenges, the DNA changes little by little. And over time, that leads to changes in the body's phenotype, or the way the body functions or mind functions. But that's a very slow process where it's actually changing the DNA. The DNA is like basically the messenger to our entire, that makes up who we are in every cell of our body. But epigenetic changes have to do with not changing the DNA itself. Epigenetics is a study of how behaviors and environment changes how your genes work. So what epigenetics means is epi is on or above the genetics. And so they don't change the DNA sequence, but they change the way the DNA works. So what happens is certain biochemical processes happen to the DNA, which is just fascinating. So there's something called DNA methylation, which is just sort of a carbohydrate group that gets like tacked onto the amino acids that make up your DNA, or something called histone modification, which is another just biochemical process of just changing the way the DNA behaves by making these sort of modifications to the DNA itself. And this is a process that causes changes very quickly, even in the immediate offspring. And this was a breakthrough. We did not know about epigenetics back in the day. In fact, I first read about epigenetics when my now 26-year-old daughter was in 9th grade, and she was reading her biology textbook, and it was talking about epigenetics. And I thought it must have been mumbo jumbo, because it also shows you how science, which tries to profess the all truth in a sense, like science can only study so much that our human brains can even get to study, right? But we understand so little about the universe compared to what is in existence. And so when I was in college, we were taught about DNA and Darwinian evolution. Well, epigenetics is something that my daughter learned about. I almost thought it was hot, hocus pocus, because it was so inundated to me, Darwinian. So, but epigenetics is fascinating because of the way the body changes in regard to stress. So an analysis of 14,000 genes in PTSD sufferers' blood samples found that compared to people without PTSD, those with PTSD were 6 to 7 times more likely to have genes that functioned unusually. And that is just absolutely fascinating. They noticed some of these changes in offspring of women who were around 9/11, like near the area of the catastrophe of 9/11. So they actually noticed these DNA changes also in the offspring. The people who were pregnant, the kids the babies, the fetuses of moms who were around the effects of 9/11. So there's also adverse childhood experiences that we see a lot of in our patients. So we see that these adverse childhood experiences, including racism, witnessing violence, a childhood abuse and neglect, these also cause epigenetic changes, as we just discussed, that can lead to PTSD, depression, substance abuse, increased rates of suicide, cardiovascular disease, and decreased life expectancy. So it doesn't mean that all stress is bad, right? Some stress allows us to grow. It's like Goldilocks and the three bears. Like there's too little and there's too much and there's just right. So there is this positive stress that's a part of healthy development. Dealing with some kind of frustrations. I mean, as we know in treatment, sometimes we have to say no to our patients, and this it does cause heart rate changes and elevations in stress hormones, but there is some positivity to it. But the body only has so much it can do until it can actually be overloaded, and tolerable stress can turn into toxic stress and lead to this adverse childhood experiences pyramid that starts off with the ACE, the adverse childhood experiences, which actually leads to disrupted neurodevelopment. There's actually a slide that I have in one of my other talks that shows the changes in the brain architecture and the disruption of normal pruning from childhood through adolescence. And the brain is supposed to do this pruning process to the neurons that are developing connections. So the brain is not able to do so. Many of the effects of epigenetics and stress are tied into the brain architecture and also associated with inflammatory responses and immune functioning, and also the serotonergic system. So that, of course, we all hear a little bit, we all, as clinicians, we remember about serotonin and mood and that sort of thing. And a lot of the inflammatory, the research around the inflammatory system is that we're understanding how the inflammatory system affects cardiometabolic, the brain, beyond brain, not just like as far as just dementia risk and things of that nature, but actual the way the brain works as far as mood, anxiety, arousal, and things of that nature. So many things count as trauma. And you throw in now the traumatic events online, the pandemic, the political divide, obviously invalidating environment. We talk about that when we think about DBT. So many ways trauma shows up in our patients. And then there's also racism itself. And that is one of the reasons why we're here as an organization today, is to address accessibility, because individuals and communities that are affected by racism, the constant coping with systemic racism, everyday discrimination is an activator of the stress response. And people of color have less access to high quality education, health services, economic opportunities, and pathways to wealth accumulation. And that's just straightforward fact. This is from Center on Developing Child at Harvard. So Black, Indigenous, and other people of color in the United States have on average more chronic health problems, shorter lifespans than whites at all income levels. So we need to really address the trauma of racism and the accessibility associated with racism. When we have more time in another talk, this is like a tangent, but it's something I want to talk more about in the future. I want to talk more about the psychology and psychodynamics of racism, because this is something that's at the heart of what we ourselves as a culture needs to address, and especially those of us who are privileged. I think as clinicians, we want to understand more about the psychodynamics of racism so we can have more of a position. It's not enough to just be like, oh, I'm not a racist, or say you're not a racist. We have to go further into taking a position around it. Just like I took a position in teaching my kids about diet culture, I'm trying to put out there that we as a community of providers need to take more of a position around racism rather than just sort of turn the other direction. I think this is something that there was the good and the bad that came out of the pandemic and social media, that there was a lot of trauma and traumatic events online, a lot of discord. There is also a lot more connection and a lot more, I think, awareness around the existence of racism, certainly with the George Floyd event that really put it right there in everybody's face. If anybody wanted to doubt that, that horrific, unspeakable event really spoke to that and created noise in our culture, which is, I think, a good thing. I'll continue on without going too much further into this, but this is something that is tied into trauma, and it's tied into breakthroughs in treatment, because we're addressing diversity, inclusion, and trauma in treatment now. And I'm very happy about that. I've made a lot of mistakes along the way, and I could have done better in a lot of situations due to my own lack of awareness. And I'm still learning all the time. I've learned a lot just by interviewing, for example, San Ching. I learned so much from that interview. So I will continue along, again, pointing out to racial stigmatization can actually change the brain. So this is why we have to really understand the gravity of it and the importance of inclusion and diversity, and understanding how that is all interconnected with intergenerational trauma and the need to address trauma in treatment, which is what this whole first segment of the breakthrough is about, is addressing trauma. It's such a gigantic subject. And there's different ways that trauma comes into our life. It could be the direct effect of traumatic stressors, vicarious, like systemic racism, and then epigenetic, that are actually passed on from one generation to the next. And this slide just gives you an understanding of how structural racism ties in together to intergenerational transmission of depression by historical trauma, adverse childhood events that all tie into intergenerational transmission of depression itself. There's psychodynamic, social culture, family systems, and biological components to the transmission of trauma. And if you think about it, the field wasn't even addressing this, because we weren't supposed to address trauma and treatment, which is pretty hilarious if you think about it. A lot of the understanding about trauma transmission, though, is as blatant as the racism has been. It more came from the understanding more of the psychodynamics of trauma transmission from Holocaust survivors. So this is something that really kind of ties into all kinds of trauma transmission. But the study and the understanding of the psychodynamics of Holocaust survivors kind of opened up the door of understanding this a little bit. And I think this third bullet point really sums it up. And if you think about it, we weren't doing this in treatment. We weren't thinking about this enough in treatment. And we still have to be careful that we don't skip it over. But I think the third bullet point really sums it up pretty well. The massive psychic trauma shapes the internal representations of reality, becoming an unconscious organizing principle passed on by parents and internalized by children. That takes my breath away and speaks to the complexity of our patients as well, and why it is, as Abhi knows, and I know he respects this too, every one of our patients that comes to us with the need for eating disorder treatment comes with such deep wounds that require such attuned responses, such deep caring and intense curiosity for the origins of the pain and the wounds. Again, these internal representations of reality, if you can absorb that, this is what our patients experience. This is how they believe. This is their worldview. We're trying to address this in ways that allow them to be more adaptable and more joyful. Certainly, socioculture is really obviously something very important that we're also addressing in our treatment milieus. I have a whole set of talks about group treatment and why group treatment is so incredibly important. That's why I'm such a big believer in smaller milieus with high frequency of individual therapy. So the milieu can sort of become a place where people can unlearn or at least challenge some of the ways that they've been brought up or the ways they're socioculturally were interacting with in their communities and also within their families of origin, and then family of origin issues as well. The biological we talked already about, with PTSD and epigenetics being really at the heart of that. Impacts of trauma. We had a couple of great talks with our trauma, some of our trauma clinicians. All of our clinicians are treating trauma. Some really innovative ways that we've worked on treating trauma in a remote setting has been really exciting for me to see the creativity in our clinicians to get into the body and to do breath work and trauma-informed yoga and modalities of art and psychodrama and just different ways that we can actually address the physiological, psychological aspects of trauma. We're actually going to be doing a training on how to do EMDR also remotely, because with trauma, it's, yes, it is real. The cognitive processing part is important, but there's a way that as the body keeps the score, as the book goes. So being able to address the way the body holds the trauma, or the way the relationship with food is really a playground, if you will, for the trauma. So Dr. Timothy Brewerton was the game changer. If he's here right now, and if this is re-recorded, and he's heard me say it, this is a standing ovation on steroids for Dr. Timothy Brewerton. He did so much research around this. He treated a patient called Sylvia when he was a young clinician, who he figured out eventually had DID, and it completely changed his framework from being more of a biologist to really having that psychodynamic formulation. And he changed things big time with his research that he did. So we could actually start doing trauma-informed, trauma-focused CBT, DBT, EMDR, somatic experiencing, and the things that we just talked about that we've been doing at Within Health. Here's some of his research. This isn't even all. I would be showing you pages and pages of all his research that he did, but these are the title of some of the research. Oh, by the way, Dr. Jessica Janae, I don't know if she's on, but she was a part of some of the research. Jamie, if Jessica's on this, will you send me a text message so I know? I just would like to know if Dr. Jessica Janae is on. She's actually a publisher in some of this research that was done at my previous treatment center. But it's so impactful. It takes my breath away to think about the fact that we used to be told not to address the trauma. All right, the next, weight stigma. Oh boy, this gets me riled up. This gets me so riled up. The BMI, oh boy. BMI entered into medicine and became the benchmark for health, quote unquote, benchmark for health. Just a very ignorant move on the part of our healthcare practices that really minimized the experience of people who live in larger bodies healthfully, really minimizing the fact that a mere equation that has to do with the height of our body, times this, times that, some mathematical equation has very little to do with like the health of any one of us. BMA, of course, ignores that people that happen to have higher muscle content might actually weigh more because muscle weighs more than fat. So some very basic, oops, that's not a very good idea kind of things. And then the problem that weight and shape were really like the benchmarks of health. BED wasn't even recognized in DSM. People did not even know what weight cycling was. There's so much talk about obesity, and I'm sorry for even saying that word. It's triggering for some people. So much talk about the O word, and so little talk about the trauma of weight stigmatization and the need to understand that health at every size doesn't mean just throw your health in the garbage. Health at every size means no matter what your body size is, we are all entitled to dignity and self-respect and self-care and loving movement and yummy food and a positive lifestyle. That's really what health at every size is really all about. It's about creating a pathway for nurturing ourselves and sort of standing up for ourselves to some extent as well. So prior to the health at every size concept, and sorry, my cat just came in the room and is meowing very loud. Prior to that, a lot of patients with BED were treated in with restrictive meal plans. There was actually a quote treatment program whose name I shall not repeat, that was a BED program that was really just a little bit more than, a weight loss boot camp, where there was tremendous amount of movement that was actually a part of it. It was really like I don't want to get too much further into it because I might give away the name of it. But it was a BED program that was really basically a way of like being oppressive towards folks, and sort of mandating movement and exercise as the so-called solution. Shavis Turner dedicated herself and her life to making social change on these issues that had to do with BED, weight stigma, intersectional social justice, discrimination, and she's a game changer because of that. And at great personal cost, I must say. She started the Binge Eating Disorder Association. She's been through a lot. Some of you may or may not know that the Binge Eating Disorder Association that we started, I think it was in around 2008. I'm a little bit confused about when that was. We eventually got BED into the DSM, and we were able to create really a platform for weight stigma with Weight Stigma Awareness Week. So BED now became a part of the National Eating Disorder Association. The organizations joined, and now I hear about weight stigma all the time, and I hear about Health at Every Size all the time, and it makes me so happy. And we get to talk about that, and we're working on it also. We're working on this at Within. There was recently, I'll be very honest, I always like to tell people the truth of what we go through as a program evolves. We've had some times and some struggles recently where some of our patients felt we didn't do a good job on this, or sometimes where we felt things felt a little bit out of balance. So we take that really, really seriously, and we're going to keep getting better. So the breakthrough was to have BED included in the DSM-5, weight stigma as part of the equation, health at every size became accepted. I wanted to find out if I should right now. We have about 45 more minutes, and we're going to getting into the last part of the meeting. Should we give each other a few minutes to just pause and stretch? So it's a very last part of a long 3 days, a fun 3 days. Jamie, would you think that'd be a good idea and let people take a little quick break?
Yes, I think that would be a great time. We can break here and come back in 10 minutes. You guys don't need to log out, just stay logged on. And we do have a question in the
Sure.
chat for you as well, Wendy, too. So if you want to take that question when we come back from break,
Sure.
that'd be great.
And if there's any more questions, I love getting questions. So feel free to chime in on your questions. Thanks, everybody. Have a little fun break.
Thank you.
Should we get started back up, Jamie? I can't remember how long we've been off now.
We have about 3 more minutes.
Okay, cool. Thanks.
No problem. While our guests will be logging back, well, not logging back because they didn't log off, but we do have 2 questions in the chat. Wendy, do you want to do them now?
I'll do the response to the one about RODBT.
Yes.
Oh my gosh, this is an area that I think is so exciting. RODBT, radically open DBT, is very different than it isn't the same as DBT. I'm very excited about RODBT. It's something that I think will be on the breakthrough list soon. And I don't know if people really know, what it is, but this is really a way to address people who have more over control issues, as what we sometimes see in also in eating disorders, and really is really less about kind of our own internal processes and more about, again, I'm not an expert, so I'm sitting here explaining something that I'm far from an expert on, but that really puts emphasis on, yes, changing behavior, but sort of having that under sort of the umbrella of really thinking how it is that relationships are formed and built. So it's beyond just mindfulness, because it's really around intentionality, around focusing on the ways we get to social connectedness. So many of the features that are present in people with certain forms of eating disorders can certainly make them, quote, successful or achieve high achieving, but can also lead to eating disorders and can sort of lead to alienation and depression and isolation. I think RODBT is fascinating. I want to learn more about it. I think it's a really exciting new modality that is really about, again, walking the walk and not just talking the talk. So thank you for the question, and something I need to keep learning more and more about. So, okay, the breakthrough that we'll talk about now is diversity and inclusion. Don't you just love Jennifer Juliana, who makes the graphics for me? Did you see how she wrote the word diversity? She's not on right now, but I have to say the name Jennifer Giuliano. She's the one that always makes these presentations look beautiful. But it's just something that we didn't pay attention to 20 years ago. We sort of acted like it didn't exist. We lived in our little privileged world, and we just thought since we were privileged, there was no issue. I made so many mistakes because of this, not having a diverse enough staff, not understanding how to approach like transgender issues. That's where I really made a lot of mistakes. But yeah, this is something that's now, it's not just like, will you or you won't you do it? Will you or will you not do you have got to manage diversity and inclusion in the eating disorder space now. And I'm happy. I think that we should give ourselves, the providers, a little bit of credit for the fact that we've taken this step. And the field, I think, is really supportive of this in general. And I think the field is excited to make these advancements. But I think I was operating from a place of ignorance, I think, for some time. Okay, didn't want to let me go forward. Okay. And then last but not least is DBT, dialectical behavioral therapy. That was Marsha Linehan that really made those advancements known. And she herself was a patient at one time. And the game changer about DBT is that it really links together some elements of psychodynamic formulation with really a very practical way to approach difficult behaviors, focusing on distress tolerance, mindfulness, interpersonal effectiveness, and distress tolerance. I can't remember if I said that one, but just really getting very specific around the behaviors that really interrupt a person's healing and growth in life. And I remember when I was first learning about DBT, the idea was suggested to me that if somebody is engaging in maladaptive behavior and they come into your therapy session and you're talking about, I don't know, like something that happened in their past or their fight with their, sister, or but they actually just did in the immediate past a dangerous behavior of some sort, or a neglectful behavior of some sort, we can get lured into that. And we can start to talk about all these other issues and not really talk about this behavior that was right here in front of us. So one of the things that we've really done in treatment is treat not just, cutting and or binging or purging, but even treat restricting as like a harmful behavior that we have to zero in on that and address that symptom in real time and not let it slip away. But getting in there also with real practical experiences. And DBT has changed the field so very much. Barely known in the 2000s when I first started. It also, what's nice about DBT is that it carries out that conceptualization that symptoms may make sense. Not that, oh, if you have symptoms, you're some crazy person, but that you're behaving in this way and it makes sense. If you ever watch any Marsha Linehan videos, she talks a lot about why people get activated and elevated interpersonally. Well, if you've been in a chronically invalidating environment where when you express needs are dismissed or ignored or devalued, or you're humiliated for them, as your needs come up, your voice is going to get louder and louder and more reactive and more dysregulated because you're not coming from a place of consistent validation. So this whole idea that symptoms make sense is really, really important. Because I think that's a very humanizing way of interacting with our patients. Not like there's something wrong with them, but that they're adapting to something that was neglectful of them. I love that. Again, I mentioned it, the validate, the valid, the invalidate, the invalid. There's also a wonderful term actually from self-psychology. I believe it's from self-psychology. The phrase, a Kohut concept, is that validation firms up the self. So why do we want that validation? There's something that we need interpersonally when we on some level, we'd like to have our emotions or our need. We'd like to have a demonstration that that's valid. I think that's a part of just making it be okay that we are who we are and what we need. So that's why in a relationship, if you have a need and the other person's just not getting it, it's very destabilizing, because that creates a barrier to intimacy. So that piece of being validated is so important. We could talk about validation forever. 6 levels of validation. It's such an important part of treatment, but I get so excited about validation that sometimes I forget, got to do the invalidation of the invalid too, because that's really how you shape behavior. The concept that the wise mind and the emotion mind both coexist. I love that. And this debunked the all or nothing thinking about a patient being healthy or unhealthy, that there's any one of us thrown into a certain situation of some sort, we can start looking pretty dysregulated. Even really otherwise healthy people getting in unhealthy relationships can start to get very dysregulated, or have scary things happen. We can start to get very dysregulated. And that's one thing that was really, really nice about DBT. And then what's also nice about DBT, and that's similar to self-psychology, which is my love, is that it allows for the therapist to truly be supportive of the patient while also drawing on the patient's strengths. And I think in that vein, it's part of a developmental model. Looking at the time here. So DBT, we talk a lot about the skills of DBT and DBT informed treatment, but sometimes we don't, I think, spend enough time understanding that Dr. Linehan came up with like sort of stages of healing in DBT. So the first stage is therapies focusing on getting behavior under control. I have a presentation that I'd love to dig up, where I was able to kind of see how what we were doing in higher levels of care and in structured treatment really dovetails with the stages of change. So the therapy getting focused on the behavior, when we give plated meals to our patient, we're sort of saying, we're going to hold the ball and we're going to sort of manage what you need right now, because the behavior is just too all over the map. So that's sort of like stage one of DBT, where we're sort of saying, well, we're gonna take care of this, right? Then we start to get into the emotional experiencing. That's the second stage, where we start to, let's first get the behavior kind of a little more stabilized here. We're going to help you with that. Then we're going to move into, okay, let's really focus on what's really the emotional experiences that you're having. That's where the validation comes in, the validation and the invalidation, but just really, and that's where connection comes in there as well. Again, there's no model of care that's only this or only that, because you could say DBT has tons of self-psychology in it. You could say it's developmental. You could say it's about attachment. I mean, there's so many things I could just sort of, in my mind, maybe it's just because I'm always looking for these connections, but I mean, because this is all about attachment too. This is all about, you can't do any of this without attachment. You can't begin to focus on emotional experiencing with a patient if you don't have a relationship. So that's why high frequency of therapy is important in higher levels of care, relationships and trust. So emotional experiencing, and then really solve the problems of everyday living, improving happiness and joy in life. Like one of my very first patients that I ever treated in a higher level of care, she had become an engineer. Her dad was an engineer and she was an engineer, and she was absolutely miserable and she had a terrible eating disorder. And when we talked about this, she talked about it in groups. Oh my God, I love some of the group dynamics that came out to help her. And she thought, oh God, it's a disaster. I just can't possibly change my career. I already have my degree in engineering. And she is now a nurse. She became a nurse. And the person that really prompted her to make that change was another peer in the group. God bless her. She was actually a lawyer that wasn't even practicing at the time because of her eating disorder. And she was very outspoken and told the patient that was the engineer, she was in her early 20s, she just really stood behind and said, you absolutely can, do this other thing. And she did. She is actually, this is somebody I treated back in 2003, and she became a nurse, and she's married and has children, and solving the problems everyday living is a very important thing, and finding joy in the path to joy. And that's really what DBT is about, is building that capacity for joy. So this is what I've talked a little bit about when I'm going through these stages. So I was saying that the motivation can be very low within the patient when they first come in. When people tell me that the patients aren't motivated for care, I'm like, and okay, that's the onus is on us to help with that, right? Our patients come in with a condition that oftentimes associated with very poor insight also. So motivation can be very external. And the eating disorder journey, the way it can come out with food when the patient's beginning to manage emotional experiencing, is that we also give that process a voice with the food. We can start to have the patient work a little bit on their own adjustment of their meals, instead of us just sort of doing it for them. That's because the answer is within, and we want to teach them to find that answer within. So the patient's still program dependent at that time, but episodically that wise mind can kick in and start being an anchor. So the clinical team or the family still has to be there to be the guardrails, but that wise mind is waking up, and we want to recognize it. By the way, when the wise wakes up, we want to capture that too. We don't want to miss successes. When we're looking at patients' behaviors and treatment teams and things like that, it's just as important to look at their successes as when they've slipped. We can get into this, oh, this happened and this happened. Well, what about this? And what about that? Capturing that and reinforcing that is really, really important too. That enhances motivation too, when we notice those good things. Then we get into that solving everyday problems. That's where the patients start to actually manage their food more and more and more. And we call it self-portioning. And that ties in with wise mind really being more in control and more leading the way. The person is able to tolerate the body without reacting to negative self-talk. So you might get up in the morning, have a negative body image day, but you can still get dressed and walk out the door and do something productive and sort of navigate through the world and navigate meals with some level of support, but also with that anchor from within leading the way. So the person who's in this stage is developing that self-motivation to recover and is having some episodic joy and peace. And then getting into the place where full capacity of joy, we sort of say, okay, they're really in that recovery place, managing their body, fully weight restored. This is a whole process that can take years to get from 3 to 4. And I used to have this hope that everybody that ever left my treatment would leave in this stage. And then I found out that that's not how it always is. So I try to be, and I mean, I think we as a team try to understand that and give each other the grace of that we aren't going to always get there this far with all of our patients, but give our patients a really positive experience of treatment so that if they do leave and come back before they're willing to come back, not traumatized by treatment. That life is worth living. And I make the point here that there are actually stages to this stage of recovery, which kind of exceed what we're going to be talking about today. A couple quick things before I share some of our outcomes, and then there'll be a little time for some more Q&A before we wind up day 3 of our summit. Psychedelics and trauma. This is another area of potential breakthrough that we're on the hub of. And Timothy Bruton was involved in some of this research. There's more and more research around the use of ketamine and psychedelics. And what's really happening with the brain here is that it's affecting these types of interventions, among many things, are affecting the way the brain can sort of change and adapt, so that the sort of having to do with neuroplasticity and brain architecture. And so again, and also transmagnetic stimulation. These are other big breakthroughs, I think, that we're just starting to talk about. And the next time we talk about breakthroughs in 10 years, when somebody else is doing the talk, they'll be talking, I think, about the use of psychedelics, ketamine, and TMS in treatment. This is really called interventional psychiatry. I'm extremely excited about interventional psychiatry. I think it is the biggest breakthrough in psychiatry in my career. Prior to this, all the treatment in psychiatry, aside from I'm talking about pure psychiatry, and there's all psychopharmacological breakthroughs. But now we're really talking about interventional psychiatry. The ability to do therapy with somebody while they're under the influence of ketamine is absolutely fascinating to me. And last but not least, I'm going to give ourselves at Within a little pat on the back. It's been a bit over a year, Abby. I don't know if you're on right now, but I hope you listen to this if it's recorded. We made it this far, and our team, we made it this far. Thank you all so much. I'm going to go so far as to say that this remote treatment is a new breakthrough in our space. It's not the only thing. It doesn't replace brick and mortar. It can be better than brick and mortar in some cases, and it can be not indicated in some cases. But the presumption that remote treatment is the stepchild of brick and mortar needs to be challenged. And I think the work that we're doing has provided evidence for this. We have Dr. Caitlin Shepard, I don't know if she's on, but she has been leading the way along with some other wonderful providers within the organization that have helped us get to the point where Dr. Shepard has the data to work with Elsbeth. Is a shout out to her, as well as Dr. Jessica Janae, that we have this data for her, and we've been really looking at this. So a lot of the brick and mortars went virtual during the pandemic. I had already started treating patients virtually prior to the pandemic and seeing really impactful treatments, but there are now modalities of treatment. I myself began to recognize the impact that this was having. And so there are new modalities that are intentionally designed for in-home care. And so there is another program, as many of us know, that's also doing remote care that works a little bit different than us. That's more of a more traditional outpatient treatment, but also with peer groups. Very innovative protocol that works with a different population that we do. But these are remote treatment has made its way. Some of the patients that we're treating in remote care also, I'll mention, are people that have actually had treatment trauma. These are some of the quotes from one of a patient that actually had been treated in a very prestigious academic institution. So remote care also can work for people very effectively who've had treatment trauma, which I'm sad to say there's a lot of that these days. And so they really just aren't able to go back to treatment due to the dehumanizing experiences that they have had in treatment. We tend to pathologize people who have treatment trauma, and we say, oh, they're just not motivated. They haven't hit rock bottom. They just, they don't really want their recovery when there's people that have really had treatment trauma. So anyway, so getting back into our remote care, it is easier to access. What are the advantages? It's easier to access. Obviously, we do all the same pre-screening that you would do if you were going to be going into a residential care when you come into our care. And as I mentioned, we work with treatment trauma. We are certainly much more accessible than any other modality of care available, I think, throughout not all 50 states, but we've had patients from places like Dayton, Nevada was one of our first patients, somewhere in the middle of Oregon, places that there was just literally no access. Making treatment more accessible to underserved populations. My co-founder, Abi, is a man who had an eating disorder, and he talks about when he looked for treatment, he didn't see himself represented anywhere. We can get in earlier in the eating disorder timeline of a person and provide really intensive treatment. And I think if somebody has a sort of more subtle-ish eating disorder, you can let that linger for years and years, or you can get in there and really nip it in the bud with 6 weeks or 8 weeks of IOP for somebody who's starting to get more and more symptomatic. Really, we can really work on the paradigm that's leading to the eating disorder, whether it's with food or the whole psychosocial dynamic that's going on in their life. So we can interrupt the progression. We can pull the family in. Jamie works on that a lot with us. We have Joe Kelly also working with the male loved ones. And even now, we are doing a group for families even before people come in to do psychoeducation. We can make an enhanced step down process so people don't go from very controlled settings and then back to their home environment with so little available to them. I think sometime we're going to look back and go, how did we even think people were going to do that? Although I've seen tremendous life-changing events from brick and mortar, and I have a brick and mortar program, so I certainly believe in the power of that. But when you do the work out within, what's really nice is the patients don't have to transfer treatment teams or think about, oh, what I did over here in this treatment center with all these people around me in this environment. Now I'm back in my home environment. Now I got to figure out how to do that. You're doing all the behaviors in the environment that you're already living in. No change of providers as you're stepping down until you go back with your outpatient team. I'm a really big believer in group therapy. I was mentioning my patient, the lovely young lady that became the nurse, and it was that other patient. It wasn't a therapist that helped her see that it wasn't anybody on the treatment team. It was that peer, and that there's so much about group therapy that can be spoken, and just group meetings in general. I mean, look at the power of AA and the force of AA and what can happen just by groups working together productively. And we create a milieu that is reinforcing of recovery. A little less inclination for learned behavior. And what's also nice is you don't have to spend a lot of time going back and forth with the patient, sort of bargaining for them to be in treatment. The disadvantages that you're not in physical contact with providers. Some of the extreme behavior is hard to interrupt potentially, maybe harder to monitor meal completion. We've actually had quite a bit of success. In some programs that are remote, they allow the patient to bring their own food, which I kind of fundamentally disagree with that concept, because I think exposure therapy is important. And if somebody has PHP or IOP level symptoms, I want to make sure they're doing exposure therapy. And it's easier to exit treatment too. All they have to do is just not show up. I'm amazed that our wonderful patients, they come to treatment and bring their full self and really get into it. And I was really worried doing this, were people going to just not show up? They show up, they come, they want help, they want to get better. And they get onto their app and they connect with the team and each other and process things. And it is easier to leave. Like, they don't have to pack up. They just don't have to log in, but they're coming in and they're staying. So I'm going to share a little bit of our outcomes now before we stop. And I'm very, very proud of this. And I'm very amazed by this. I never knew really what was going to happen with our program, like what were the outcomes going to be. We did all the same outcome measures that the Residential Eating Disorder Coalition did, which is the EDEQ, the PHQ-9, the State Trait Anxiety Index, the EDQOL, and then we added also intuitive eating skill, because the intuitive eating, so not everybody comes in as an intuitive eater. We just keep that more as a light, as it's like the idea of intuitive eating is like a light. We were always leaning towards the light because that's how you develop. But the Red Sea didn't do that. But the EDEQ scores are really interesting. That's a score that's very, very high. That's consistent with and high clinical acuity with a 3.38, leaning toward the acuity of somebody who's on an inpatient unit. Our patients, by the way, the average number of years that our patients have had eating disorders, I don't think that I have this on a slide, is 12 years, which is really significant. This is the percentage of that have had facility-based treatment and the different kinds of facilities. So 39% of our patients have had residential treatment in the past 5 years. 14% have had, or almost 15, past psychiatric treatment. Almost 11% have had past medical treatment. 37% PHP, 25% IOP. Our patients have been through a lot. They've been through a lot of facility-based treatment. This is the average and highest number of treatment admissions. So we've had patients that have had 7 medical admissions, 9 residential admissions. We've had patients that have had up to 180 days of residential lengths of stay. These are patients that have been very sick. Our number one referent right now is actually a program that treats very medically compromised patients. And so we are able to work with medically compromised patients, and that because we have a high level of nursing involvement, very high level of nursing involvement. We have amazing, amazing nurses, by the way, led by Chrissy Stockert. So this is just some more data around our how we're doing. This is how we're doing. So the EDEQ scores are coming down remarkably. EDQOL, depressive symptomatology, the EDEQ and the EDQOL are really consistent with significant change. The depressive changes are more consistent with moderate change, but all very, very statistically significant. And this just shows here if you can look at the top, you can see after about a month, our patients' scores on the EDEQ scores are starting to drop below what we call clinically elevated. This is admission to 2 months, and this is admission to completion. This is why it's really important for people to complete treatment. I've never had anybody tell me they stayed in treatment too long. I kid you not, nobody ever left treatment and said, Wendy, I stayed in treatment too long. We got to get our folks to finish treatment, because it's that last leg of the journey where it's stage 4, 3 or 4 with DBT, building that life worth living, getting more comfortable in your body. Oh my God, that graph makes me so happy. I could just dream of that. But see what happens when they stay after that first month and they follow all the way through. And this is the same thing you see for the depressive symptoms. It drops below clinical about a month into it, and then it just keeps going down if the patient stays and waits till the end of treatment. State trait anxiety is a reduction in anxiety symptoms after 2 months. Getting into the 40s is where you start to get into non-clinical. So I just think this is really fascinating. And Elsbeth, if you're listening, thank you for all the outcome stuff you did. And I know we have other people helping now get our outcome data. Jessica Janae, thank you for putting up with me and heading this off until the lovely Caitlin, Dr. Caitlin Shepard came on board. We wouldn't have this data if it wasn't for you all. The QOL, here's after 2 months, and you can see below the psychological, physical, financial, and work school QOL. Quality of life changes. And then over till we get to discharge. And we do have significant lengths of stay for many people. So that's why this is discharge. Discharges can be many months or a few months, depending on the patient. So this brings me joy to see this. I'll leave it to my two quotes. Most people who know me know this quote. This is really what it's about for us, is to actually dive deep and swim far. Be not a slave of your own past. Plunge into the sublime seas, dive deep and swim far. That's what we have to do with our patients and ourselves, so that you will come back with self-respect, with new power, and with an advanced experience that shall explain and overlook the old. Jane Goodall said, only if we understand can we care. Only if we care will we help. Only if we help shall they be saved. And here we all are. Probably most of us on the call right now are providers of care. It's 5 o'clock on a Friday. Only if we help shall they be saved. Thank you very, very much, Jamie. Thank you.
Thank you so much, Wendy, for that amazing presentation and all of the wonderful information. We do have some questions for you in the chat. One comes from our attendee that says, could you please give an example of invalidating the invalid?
Sure. The first time I ever learned about invalidating the invalid was a clinician that worked for me, taught me that. I'm a softie, and one of our patients in my very first treatment center was having an absolute conniption fit regarding the type of yogurt that we had provided to her. And I, being a little naive in the moment, I must say, thought to myself, oh dear God, did I buy the wrong kind of yogurt? Should I be providing yogurt X instead of yogurt Y? And I was about to indulge the patient in that. And the clinician said, now that doesn't mean we say, oh, you're crazy for wanting that other kind of yogurt to the person, but we have to say to the person, we see that this kind of yogurt X, you prefer over yogurt Y. And that's the whole thing of DBT. And we also think that it's important to be flexible and be able to eat yogurt X instead of yogurt Y. And the fact that yogurt X is here versus yogurt Y is actually not a sign that this is a terrible treatment setting for you. So that's invalidating the invalid. I hope that made sense.
Thank you. And our other comment comes from an attendee that says, do you have a link to the study referencing the pregnant mothers during 9/11 and the effects on the children? This particular attendee said that she was pregnant during 9/11, struggling with disordered eating, and her daughter has anxiety and possible mental emotional challenges.
we can get that. If you can please send your contact information to Jamie, I'll be sure that you have, we send over that that research to you. Thank you for asking those questions. Did we do it, Jamie? Did we wrap?
We are.
Questions?
We do not have any additional questions. I will go back through the chat. I don't see anything else here, just some comments that this has been very helpful. Thank you for this. Oh, we do have one other comment. This particular person in the comment section has said, Dr. Pyatt, do you find that you miss working with patients every day like you did in a traditional brick and mortar setting?
Yes, I do. I have the benefit of also working in brick and mortar at times as well. So I'm spoiled. I get to have my cake and eat it too. I was actually giving a talk this morning. This is the world's record for the most I've ever talked in a day, for sure. I did a 3-hour talk this morning in person in Fort Lauderdale. And whether it's with patients or other clinicians or whatever, it really feels nice to be physically together with people as well. We had a dinner last night for Within in Fort Lauderdale and then multiple other cities. And I do think that physical connection is also really, really valid and important. And so, yes, I do. I miss that. And I think during the pandemic, we all got, I guess I got so used to being by myself all the time. I got a cat that is very spoiled and running around here somewhere. And I was with myself so much. And then when I started going out and interacting with people, I'd be like, oh, this kind of feels good. Like it was almost like I forgot that, oh, it's kind of cool to be around people. So yes, I do at times miss this. And we believe at Within, I'll just mention that, that really we are creating greater connections for people. And we do think this is a positive modality of care. It doesn't replace brick and mortar, and some people may choose brick and mortar as well. And we fully support that as well. And all the programs out there that are doing wonderful work. We love all of the providers in the community. I do think that this modality helps a great deal though during the step down process. I've seen amazing. It makes so much sense, that it's so hard to transfer from brick and mortar to home. So
thank you, Dr. Pyatt, and thank you to our attendees. We have several comments in the chat that says this is a great presentation. They're very grateful. And I also want to just shout out that our attendees are a mixture of providers, families, and alumni.
really?
We have some alumni
Oh my
in the chat as
God.
well. So
Yeah.
thank you.
Oh
All
my
of
gosh,
you.
thank you, alumni. We're going to keep doing more and more and more alumni stuff. Tell the other alumni we're going to be here for you, and we want to be a part of your journey going forward. And you'll be working with Jamie. You'll spend time with Jamie as you do that. I'm really happy there's alumni here. I'm really happy there's family here. Thank you guys for coming. And thank you, everybody from Within. Thank you, Avi, my co-founder, who believed in this. Garrett, Jessica, Chrissy, Sean, Fareed, Ophir, Stacy, Wendy, the original group, Mateo. Thank you all for making this happen.
We appreciate you. This is the conclusion of our first annual Within Health Summit. Thank you again. Don't forget to check your dashboard. I mentioned earlier that some of you had some questions regarding your certificate. We will get your certificate with all of the sessions that you attended. So therefore you won't have 4 and 5 different pieces of paper. So all of your hours will be calculated on one certificate once you complete the surveys and the conference summit has officially come to an end. So thank you. If you have any questions, do not hesitate to reach out to me. And we wish you all a wonderful weekend and stay safe. Thank you so much. Thank you so much, Dr. Pyatt.
Bye.